There are, of course, other immunotherapies being looked at in squamous cell carcinoma of the head and neck. Now that we have the proof of principle that nivolumab and pembrolizumab clearly work, as you can imagine, there's a lot of excitement to look at other immune agents. The first group of immune agents are the anti-PD-L1 antibodies that in other cancers have shown similar activity to anti-PD-1 and have garnered approval in lung cancer, bladder cancer, and some others. And of course, as you might guess, they're being evaluated in head and neck cancer. For instance, durvalumab is being evaluated both as a single agent and in combination with anti-CTLA-4 antibodies. Avelumab, again, an anti-PD-L1 antibody, a somewhat unique anti-PD-L1 because it is an IgG-based antibody, and in theory should also activate ADCC, another arm of the immune system. It's being evaluated in head and neck cancer. We will soon see data as a single agent in recurrent metastatic patients, and there is an ongoing phase 3 study looking at avelumab in the context of chemotherapy radiation compared to chemotherapy radiation alone. This is a 600-plus patient trial that's being conducted internationally, moving immunotherapy now into the locally advanced curative setting. And then lastly, atezolizumab, although hasn't been rigorously evaluated in squamous cell carcinoma of the head and neck, those studies are beginning to look at other settings, for instance, the neoadjuvant setting, other settings in the locally advanced disease space, and some settings in the adjuvant space. So we will see several PD-1, PD-L1 antibodies in squamous cell carcinoma of the head and neck. It would not surprise me if a few of those, if not all of those, were eventually approved in different patient populations.
There are many outstanding studies evaluating the role of immunotherapy in the first-line setting. As one example, the Kestrel trial randomized patients to single-agent immunotherapy with durvalumab, the combination of the PD-L1 inhibitor durvalumab with the CTLA-4 inhibitor tremelimumab, or standard of care chemotherapy, the extreme regimen of platinum, 5-FU, and cetuximab. That effort has completed accrual in the US and is finishing in the rest of the world now. There are similar studies ongoing with other agents, including nivolumab, that will help answer these similar questions. I think based on the data that we have in the second line, it's very promising for immunotherapy to replace chemotherapy in the front line, but we're going to have to wait and see what the data actually shows. There are dual rationale for combining PD-1 or PD-L1 inhibitors with CTLA-4. One is that these are both T-cell checkpoint inhibitors involved at different stages of T-cell activation. The other is that they're both clinically available with extensive safety data, and that there have been favorable clinical results in melanoma.
The natural progression of immunotherapy now is to go and build on what we're seeing with the anti-PD-1 antibodies and try to combine different immunotherapies. The first combination that entered the clinic in a systematic way was with anti-CTLA-4, nivolumab and ipilimumab, and durvalumab and tremelimumab. The one with the most mature data is ipilimumab and nivolumab. Although we don't have data in squamous cell carcinoma of the head and neck, we do have very promising data in non-small cell lung cancer, in renal cell carcinoma, and earlier than that in melanoma, suggesting that the combination can increase response rates substantially, with the caveat that it does also appear to increase the adverse event profile, going from about 10% grade 3 for AEs with anti-PD-1 alone to as high as 50%, although as we've learned to use these drugs together, that grade 3 adverse event rate has dropped to about high 20s to 30%, but still clearly higher than anti-PD-1 alone. Another interesting combination is lirilumab and anti-PD-1. In this case, it's nivolumab. And we saw some very exciting data at last year's SITC meeting with that combination in squamous cell carcinoma of the head and neck, specifically a response rate that appeared to be higher than nivolumab alone, in fact, appeared to be about double what nivolumab did in Checkmate 141, around 25%. Interestingly, most of the responses were in patients with PD-L1 positive disease, suggesting that we may be able to enhance the response rate in patients who have a pre-existing propensity to respond. Relatlimab is an anti-KIR antibody, so it affects another part of the immune system, namely NK cells, but that may also have an effect on T regulatory cells. So this idea of combining different mechanisms of the immune system to enhance the response appears to be playing out in some very real ways. When we think about squamous cell carcinoma of the head and neck, we have to begin to consider not only patients with recurrent metastatic disease, but how we are going to treat the majority of patients that we see, and those are the ones that present with locally advanced disease. Those are patients who we will attempt to cure in many cases, so this is a curative setting. And there is a at least widely held hypothesis that immunotherapy would be able to impact those patients to the same degree or perhaps even to a greater degree than patients with recurrent or metastatic disease. In that context, we now have phase 3 studies looking at immunotherapy in the context of chemotherapy radiation. One of those trials, the Keynote 412 trial, compares standard chemotherapy radiation, cisplatin radiation, to pembrolizumab added to standard chemotherapy radiation. We now have phase 2 data that are being presented at the American Society of Clinical Oncology demonstrating that the addition of pembrolizumab to cisplatin radiation is safe. It does not appear to impact the ability to deliver curative intent therapy. So very important to know that prior to phase 3 studies. And of course, the phase 3 trial is now attempting to improve survival in high-risk patients being treated with curative intent with locally advanced head and neck cancer.
Head and neck cancer in general is a little different than some of the other cancers that we discuss on OncLive in the sense that the average patient is locally advanced and treated for cure. And that's very important in any discussion of head and neck cancer. The current paradigm for the treatment of these patients is typically the combination of cisplatin with high-dose radiotherapy or cetuximab with high-dose radiotherapy. There are many attempts to integrate the immunotherapy agents into attempts at cure. We can start chronologically in terms of a patient's path. Chronologically, the first place that these are being studied is in combination with chemotherapy. So neoadjuvant therapy, or as we call it in head and neck cancer, induction therapy. Using PD-1 inhibitors either alone or in combination with chemotherapy prior to whatever is used to try to cure those patients. And multiple of those studies are ongoing or planned. The next phase is to combine these agents with radiation. And there are two ways to do this. You can combine them with radiation alone. So an example of that might be my 1509 study that combines pembrolizumab with radiation. Alternatively, you could try to graft these agents onto existing paradigms. We will see safety data at ASCO in a few days on the combination of platinum and radiation, a standard therapy right now, plus the addition of a PD-1 agent. And there are similar studies being done with cetuximab radiation and the PD-1 agents. And we'll have to see what all of this data shows, both for safety and for efficacy. All that we know so far is that the combination of platinum, radiation, and PD-1 is at least safe. The final way to study these agents is adjuvant therapy. And there is a study planned, I believe it started already, just started, using pembrolizumab in the adjuvant setting. Which of these will be the right way to go? We have a long time until we're going to be able to answer that, but I think they all merit study. They're all appropriate, promising studies that I would put a loved one on if they were unfortunate enough to be in this situation, and we'll just have to wait to see which looks best.